In this video, we will talk about febrile neutropenia. We will cover the definition of febrile neutropenia, diagnosis, and management. Febrile neutropenia is defined as a single temperature of 38.3 Celsius degrees or a temperature of 38 degrees for over an hour. This in addition of an ANC of less than 0.5 or less than 1 with a predicted nadir of 0.5. The nadir of neutropenia occurs between days 7 and 14 after chemotherapy. It occurs in between 5 to 30% of solid tumors, and it can occur in up to 80% of hematological malignancies. We will only identify any source of infection in only 20 to 50% of cases, and we will find 10 to 30% of those with febrile neutropenia will have bacteremia. It carries a high mortality rate that ranges between 4 to 20%. Some common sources of bacteremia are central lines for Staphylococcus. There can also be translocation from the gut. In this case, we will see E. coli and Pseudomonas, or it could also come from the respiratory tract, and in case it would be a Streptococcus. Fungal infections can occur in patients with prolonged neutropenia, meaning more than 7 days, prolonged antibiotic use, TPN, or mucositis. For diagnosis, we will start with a thorough medical history, which will include a comprehensive review of symptoms, medical comorbidities, chemotherapy regimen, date of last cycle, prior infections, antibiotics, and resistance. We will also perform a thorough physical exam, including the skin, catheter sites, perirectal area, and neurological exam. For the workup, we will include CBC and differential, blood cultures, chest x-ray, and then the rest will depend on what symptoms the patient is presenting. For example, if they have a skin rash, we will get a biopsy. Always keep in mind that these patients won't be able to mount a robust inflammatory response, so febrile neutropenia may be the only sign of infection, and the chest x-ray sensitivity will decrease. For the management, we will first stratify our patients in high or low risk of poor outcomes. We will use the Multinational Association for Supportive Care in Cancer score, or MASC score. This score can be easily found online. For example, MedCalc has it included in its calculators. This score includes things like burden of symptoms, hypertension, COPD, or the previous presence of fungal infections. The higher the score, the less likelihood of poor outcomes is predicted. If we get a score of 21 or higher, outpatient management can be considered. Some of the things we will take into account are whether or not the patient lives within 1 hour of the hospital, if the patient has a caregiver at home, or if the patient can return quickly to the medical center. For those patients at high risk of poor outcomes, we will treat as inpatients. We will start broad-spectrum antibiotics within 1 hour. The Infectious Disease Society of America recommends monotherapy with anti-pseudomonal beta-lactam agents such as cefepime, ceftazidime, or piptazo. If you are suspecting a catheter-related infection, or your patient is not responding to treatment or is hemodynamically unstable, coverage should be expanded to include resistant species such as MRSA, VRE, or ESBL. Fever persists after 4 to 7 days of broad-spectrum antibiotics, we will start antifungal coverage. In summary, febrile neutropenia is defined as a temperature of or above 38.3 or a temperature greater than or equal to 38 degrees for at least an hour, plus an ANC of less than 0.5 or less than 1 with a predicted nadir of 0.5. We will risk stratify using the mask score, and with this we will direct inpatient or outpatient management. Those with high risk of poor outcomes will be treated as inpatients with broad-spectrum antibiotics. And don't forget that at any time you can consult infectious diseases.